Ventricular septal defect, VSD, is one of the most common types of congenital heart defects. It is characterized by an opening in the septum that separates the heart's two lower chambers, the left and right ventricles. VSDs are typically classified as acyanotic congenital heart diseases because, in most cases, oxygen-rich blood flows from the left ventricle, high pressure, to the right ventricle, low pressure, resulting in increased blood flow to the lungs without causing cyanosis, bluish discoloration due to low oxygen levels in the blood. VSDs are classified based on their location in the ventricular septum. Paramembranous VSD, near the membranous portion of the septum, close to the aortic valve. This is the most common type of VSD. Often closes spontaneously, especially in small defects. Muscular VSD, located in the muscular portion of the septum, can occur anywhere in the muscular septum and may be single or multiple, more likely to close spontaneously compared to other types. Inlet VSD, near the tricuspid and mitral valves, in the inlet portion of the ventricular septum. Less common, often associated with other congenital defects like atrioventricular septal defects, AVSDs. May be associated with genetic conditions such as Down syndrome. Outlet supracrystal, VSD, near the outflow tract of the right ventricle, just below the pulmonary valve. Relatively rare, more common in Asian populations. Often associated with aortic valve prolapse, which can lead to aortic regurgitation. Left to right shunt. In VSD, oxygen-rich blood from the left ventricle flows into the right ventricle due to the pressure difference between the two chambers. This causes increased blood flow to the lungs, which can lead to pulmonary overcirculation and, eventually, pulmonary hypertension. Heart enlargement. The increased workload on the right ventricle and lungs can cause hypertrophy, thickening, of the right ventricle and enlargement of the left atrium due to increased return of blood from the lungs. Small VSDs are often asymptomatic and may be detected incidentally by the presence of a heart murmur. Many small VSDs close spontaneously within the first few years of life. Moderate to large VSDs can cause symptoms such as a characteristic loud, harsh murmur heard during auscultation, poor feeding and growth, tachypnea, frequent respiratory infections, and heart failure. Complications of VSD include pulmonary hypertension, which can cause irreversible damage to the lungs, Eisenmenger syndrome, where prolonged pulmonary hypertension can reverse the direction of blood flow through the VSD leading to cyanosis and aortic regurgitation, particularly in outlet VSDs, where the aortic valve may prolapse into the defect. Diagnosis of VSD involves echocardiography, chest X-ray, electrocardiogram, ECG, and occasionally cardiac catheterization to assess the defect size, blood flow, and any associated complications. Management of VSD includes medical management such as diuretics, ACE inhibitors, and nutritional support to manage symptoms, particularly in infants with heart failure. Surgical management is typically recommended for large VSDs causing symptoms or complications, and involves open heart surgery to close the defect with a patch. Percutaneous closure is suitable for some muscular VSDs or small paramembranous VSDs accessible for catheter-based closure. Regular follow-up with a cardiologist is essential to monitor the size of the defect, symptoms, and potential complications such as pulmonary hypertension or aortic regurgitation. Ventricular septal defect is a common acyanotic congenital heart disease that can range from being asymptomatic to causing significant symptoms and complications. Management depends on the size of the defect, the presence of symptoms, and the risk of long-term complications, with treatment options including medical management, surgical repair, or percutaneous closure. Early diagnosis and appropriate intervention are crucial to prevent complications and ensure good long-term outcomes.